Hi, Dr. Dash.
Hey, Daryl, good morning.
Morning. So, welcome to the conference.
Thank you.
Glad you're here, or everybody's glad you're here. Can you tell us what kind of doctor you are and where you practice?
Sure. So I'm a urologic oncologist in Seattle, Washington.
Okay.
See, yeah, and in treating prostate cancer patients and the other urologic cancers.
So, do urologic oncologists just focus on advanced stage, or you do surgery, or what?
Yeah, so that's a good question. We are trained as urologists, uh, so treating kidney stones and BPH, but also the different urologic cancers. And then um, there are fellowships after residency. And so one of the fellowships that urologists can then pursue is one in oncology. So then you focus more on the treatment of urologic cancers and the surgical aspect, but we also have the good fortune of learning about the other treatments, chemotherapy, radiation, et cetera.
Yeah. So, your day-to-day patients, though, are they all stages or just advanced?
They're all stages. So maybe a little bit more towards the lower stage cancers, the localized cancers, but we end up treating the whole gamut.
Great. Well, that's really good experience for today's conversation, which is we're going to talk about all the different tests and scanning opportunities, but mostly tests around that are useful for each stage of prostate cancer, which is to say, each person with a unique stage, early, middle, late. Um I'll let you figure out how to characterize it in the
Yeah.
most useful way. So why don't we start with, I guess, a guy who's newly diagnosed with an early stage, sort of low to intermediate risk cancer.
Okay, sounds good. Actually, Daryl, let me even take a step
Oh,
backwards
go,
because
please.
so this case scenario is interesting because this is a guy who just came in, he got the cancer diagnosed, but maybe we could just kind of dissect backwards and think about what happened to him, how he got to our office in the first place. And so,
Excellent.
yeah, so um, most frequently in the United States, prostate cancer is diagnosed after a man has a routine screening PSA blood test. Um, and that leads to so that screening test was ordered by the primary care doctor typically. And then the primary care doctor then usually refers the patient then on to a urologist. Uh, Oftentimes it's useful to repeat the PSA, simply because that first PSA could be a spurious elevation, and especially if a patient hasn't had any old PSAs for comparison, then all of a sudden you have the first one, and you want to know um, if that's real or not. Um, and so um, so then it's worth repeating, and then as we think about additional tests, see, really here's the first kind of disease state where we start thinking about applying new technologies. And here these include blood tests or urinary tests. So these can help dissect out a patient's risk. And when we talk about these kinds of tests for any disease state and largely for any disease, we always got to think in our heads, what is it? What is the question that we're trying to answer from this test? And you think of these tests as, are these offering us prognostic information, or are these offering us information that guides therapy? And you can divide the test into that kind of broad categories. And so the prognostic test will just kind of give us an idea what's a person's risk. And here in this one, with this guy with the high PSA, we want to know more about his risk of having a cancer, a prostate cancer, and not only prostate cancer, but what we call a clinically significant cancer, one that might be more aggressive. And so here, this is a place where a couple of tests come in, and these are sort of adjuncts to PSA. Some of the common ones are the Prostate Health Index. Another one is called the 4K score. So these all take other molecules that are similar to PSA and throw them together into kind of an algorithm and weights them, and then gives us a little more information on the specificity of the test. And
And
so then
where do you get these molecules from?
yeah, so these are just secreted. They're oftentimes the PSA is processed or broken down. So free PSA is a common component of those two tests: the free PSA, the total PSA. The 4K score includes human kallikrein 2. That's a member of the kallikrein family along with PSA. So those are the places they come from. That's a good question, because they're coming from the prostate and being processed. So those are those kinds of tests. There's also urinary tests, urinary PCA3. There's another one looking at a Tempris 2 in the urine. But the idea behind all these tests is to increase our detection, sort of the accuracy of finding a more clinically significant cancer. So if the patient especially is on the fence about whether to undergo biopsy or not, because the only way we'll really know, hey, do I have prostate cancer or not, is to undergo a biopsy, like our case scenario patient, then some patients are reluctant, and maybe the doctor's reluctant. And so we're trying to use that information to make that decision. And then finally is really the context of the patient's, where is he coming from? Is he elderly? Is he healthy? Does he really need to undergo a biopsy in the first place? And so this information might kind of help us decide that. If you have a person who you're trying to weigh his other health conditions and so forth, is it do we want to know that he's got prostate cancer? Is that going to make a meaningful impact on his life by diagnosing it and then potentially treating it if he's got other health problems that are really going to hurt him before any prostate cancer would? So those are some of the tests that are useful in predicting somebody's risk. But then the other important one is the MRI, and this is generating some controversy. Because the MRI is an expensive test, but it can give us a picture of the prostate. And so that's the important thing. It's giving us some a picture that not only says, hey, there's an area of the prostate that looks funny, that looks suspicious, but the fact that it's there or not. And so if a patient, you could say, let's get this MRI and see if there's anything suspicious, and then let's do a biopsy. And so in some ways you could say, oh, okay, yes, you have some spot there. We see it very clearly. Okay, let's go ahead and do a biopsy. Or vice versa, the prostate MRI could look totally clean. There's not a single thing there. And then do we feel comfortable saying, oh, that looks good, let's leave you alone? And so that's where now we've opened up this little bit of a can of worms here, because just identifying a lesion, a suspicious lesion on MRI, the positive predictive value of that is fairly good, but there's a great deal of variation amongst different places that do the MRI. Then also, is there some likelihood of finding a cancer in the areas that are adjacent normal areas? So we think of doing potentially not only getting a biopsy of that bad looking spot, but then also the normal areas.
Right. So far, we've talked about blood, urine, and imaging.
Yep.
But none of them, is it fair to say that actually none of them describe prostate cancer? They describe suspicion and risk, but nothing is actually, I mean, you can't draw blood, run a test, and say, you've got prostate cancer, you don't. You can't, right.
That's true.
Right.
Oh, yeah, yeah.
And the idea of an MRI showing an image, though likely, because what else? I mean, there are other things. There are stones and stuff there, but it still doesn't tell us where's prostate cancer.
Correct.
And that's sort of, I think, the challenge that patients sort of meet head on with the question, why can't you tell me? I mean, it's 2020, entering 2021. What's the big deal? Why do I have to undergo a surgical procedure to identify whether or not I have prostate cancer?
Right. Well, no, that's a great question. and and of course people in the research labs are working on it and looking at in particular circulating tumor DNA and so forth, things that could be detected on a liquid biopsy per se, but especially in that disease state where there may not be a high volume of cancer, where these kind of genetic materials are being released in the circulation. We just aren't there yet. But of course, that's what everyone's working on. And the reason for that, and like you're alluding to, is the biopsy. Yes, ultimately, we're just getting this information to say in our heads to the doctor and the patient, hey, yes, are we concerned enough there's a prostate cancer and we want to know about it, and then go ahead to do that next step with the biopsy. So all, like you summarize there, that yes, all these tests are just giving us idea of somebody's risk. So the related to this though is one one additional bit of technology, which is called MRI fusion biopsy. And that's where we have that MRI picture, we do see a suspicious lesion, and we can use that image from the MRI and put it into our biopsy machine, and then make sure at least that we, when we do the biopsy, that we're getting a piece from that area. And there are even different ways to do that. There are machines. There are two prominent manufacturers of the machines where that the MRI image is imported into our ultrasound biopsy machine, and we can calibrate so we're overlapping our live ultrasound with the MRI picture, and can then make sure that as we're moving our ultrasound, we're getting the spot we see on the MRI. Oddly enough, though, actually some data says that that kind of machine-based fusion isn't better than the urologist holding the biopsy probe by hand and just saying, okay, yeah, I see the prostate, I know it's in that part of the prostate, I'm going to make sure I get a piece from there. And that's called a cognitive fusion biopsy. So you're just really just using your your mind's eye to get that piece.
Right,
So
and just to be clear, the second manner, the second method
yeah,
that you just that it still involves the MRI and an ultrasound,
right,
just a
yeah.
different way of looking at it, as opposed to using a machine to sort of overlay. You're just going back and forth with your head, more or less.
Correct. Yeah.
Yeah.
And in some ways there's advantages to it too, because the machine-based fusion biopsy is time consuming. So the patient is in the office for a while we're getting all the stuff calibrated and things like that with a probe in there. And so it can be uncomfortable. And so the reason why I wanted to bring it up was because maybe the urologist a patient sees doesn't have that equipment, but that isn't to say that the same quality of diagnostic determination with just a handheld cognitive biopsy would be any compromised. So
When the multi-parametric MRI thing was introduced, several years ago, throughout all of our support groups across the United States, everyone's getting excited. Like, new guys will, just have 1 to 3, pokes, 1 to 3 harvests of their prostate.
right,
And then now, within the last 2 or 3 years, we have we collect a lot of history and intakes and things, and we see they're not just getting the standard 12 core,
mm,
hole, but they're getting 2, 3, or 4 additional pokes,
yeah,
to match up to the MRI.
right.
Um, what happened to that promise of minimal invasion?
Yeah. So the like you said, the idea was in the beginning here, could we simply rely on the MRI alone to identify the suspicious lesion? But you'll find perhaps up to 25% of people in the adjacent normal prostate will have a clinically significant cancer. So in that way, you 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 could potentially miss a cancer by just doing the biopsy on the suspicious identified lesion seen on the MRI. So so that's the rationale behind doing that additional beyond the beyond the 2 or 3 dedicated ones to the suspicious lesion, plus our what we call our standard template that we do on top of that. So that's where that additional 12 comes from.
Yeah. And then the interpretation of what it looks like, what the flesh looks like. And neither of us are
Yes.
pathologists, so, it's not really, not much we can contribute to that discussion, but it's still like an art.
Yeah, that's absolutely true. And thanks, Daryl, for bringing that up, though, because the pathology interpretation is actually somewhat subjective, and there are studies that show even amongst an individual pathologist, if they're looking at a whole bunch of slides and the biopsy slides, and they come back and look at one they looked at sometime before and look at it again fresh, they may score it differently. So so it is somewhat subjective, and the pathologists are trying to make it, every day trying to make it more uniform and standardized, but there for sure there's some subjectivity, which brings up kind of the second space where we'd think of applying some of these tests. And there are a variety of molecular tests that can be applied to the biopsy samples. So here there are these gene expression tests, and you may have heard, I'm sure, of some of them. There's the Polaris test from Myriad. There's Oncotype DX. Another one is called a Decipher. So so these are all looking at some sort of proprietary gene expression signature. And from that, they're trying to say, well, okay, this person has that intermediate risk prostate cancer, kind of the middle of the road, but are they more towards the bad side of intermediate or more towards the good side of intermediate? So in that, if we could call it intermediate prostate cancer that our scenario patients in, which end of the spectrum does he lie? And so that's important because, again, we're applying that test to help us answer a question. And that question that we're trying to answer is, what's the best treatment for this guy? And here, this test may give us some idea, at least about the nature of his cancer. It doesn't say that one treatment is better than the other, but it just gives us an idea of the nature of his cancer. So those are 3 common tests that would be potentially run on the biopsy tissue. Now, it's important to sort of distinguish those kinds of molecular tests from, another aspect of testing that I'm sure other speakers will discuss, and we can talk a little bit about, but that's germline testing. And that's where we're looking for some underlying heritable genetic mutation. Whereas these tests that I described are looking simply in the tumor tissue. So for expression of certain particular genes or pattern of genes that could indicate a more aggressive nature prostate cancer.
Let's talk about the idea of 3 tests. There are 3 different kinds of, and actually there are several more. They're just not heavily marketed, and some aren't.
Right. Yep.
Yeah. So, I mean, should a patient? I mean, my feeling is that each test will present a slightly nuanced, different result.
Right.
So how do you use that in helping a patient determine treatment?
Yeah, ultimately, you could even it makes it quite difficult, and it could potentially you could potentially even have contradictory results from these tests, because each proprietary test is looking at some different component. But nonetheless, I think the really the application of any of these tests, it's useful for the patient and the doctor to think about what is it they're trying to answer specifically. And so really the main question is that patient going to choose between active surveillance, closely monitoring the cancer, versus some active treatment, surgery or radiation treatment? And if the patient clearly knows in his head, I'm going for surgery, then you don't really need that test. But if the patient's on the fence as to which way to go, then these tests can help at least give a little bit of confidence to the decision making. And then, but to answer your question of how to interpret them side by side, there isn't good data to say one is clearly better than the other. So, and the reports. The reports of these tests, when you get them, they can be a little bit confusing, and they're not exactly the way they report the data isn't exactly the same. So so there's some nuance and subtlety to it.
Yeah. And by the way, there's construction going on outside, so
Oh,
I'm going to mute myself every now and then.
okay.
But the idea of 3 tests, the doctor has the opportunity to choose any or all of them. I mean, is this something that you discuss with the patient, who really initially certainly doesn't have a clue what's going on around molecular testing? Or is there does a doctor with experience with, well, 3 of these tests, are they capable of knowing test A is more likely to give a more dire report, test B sort of a crapshoot one way or the other, and test C is less likely to suggest a concrete treatment for the patient? So if I've got a nervous patient, and I feel comfortable sort of navigating them towards an active surveillance thing, I'm going to choose test C, which is more likely to give them a better report. I mean, is there that kind of like, just like there's doctor shopping, is there test shopping by the doctor?
Oh, that's that's a good question. I don't know the answer to that. But because the results are somewhat vague, they can be presented in a certain way, certainly, to give the patient confidence in their treatment choice. So that, I don't know if that doesn't quite answer your question, but I'm not aware of any research data that says that people are choosing a certain test for desiring a certain outcome of that test, to direct the treatment.
Like all things prostate cancer, there's a lot we don't know.
Sure.
But I mean, I think we should have labeled this talk more like, what do I want to do and how do I figure it out?
Right. Sure.
I mean, it's not like any of these tests are giving, or anything we're doing in our realm is giving us clear pathways towards something.
Correct. Yep, that's absolutely right. So it's always, if I could harken back to what we talked about in the beginning, is that it's always thinking about, from the patient doctor perspective, what are we trying to answer? What what pathway are we leaning towards treatment, and does this information from a test or so forth help us decide which way to go? And so if a patient, no matter what their disease state is, if it's before they had diagnosis or after diagnosis, so you really just want to use these tests to answer a question about what pathway to go, which fork in the road are we going to go down. So
what do you think we should talk about next? What's next?
Yeah, right. So we went through the diagnosis, and now we have prostate cancer, and now we talked about the different kind of risk categories a little bit, we alluded to. And so ultimately, though, we take all of the patient's clinical parameters. And if you look at our different professional guidelines, they still rely on the basic clinical parameters that we all get to determine a patient's cancer risk category. And there are different systems to categorize that risk. Many of us look at the D'Amico risk criteria, and now that's sort of evolved over time, and many of us now use the NCCN risk categorization. And again, those incorporate the clinical parameters, which are the patient's clinical stage, when the doctor could do the DRE and feel something, the PSA level, and that biopsy information, in particular the Gleason score and the volume of cancer. So those three things, the PSA exam and biopsy information, are what's really determining someone's risk category. And when you look at it, it's a kind of a table. So there are some rather arbitrary lines of risk categorization. And there's another system called a CAPRA system that kind of makes it a little bit more smooth risk categorization. But nonetheless, we're taking that information, then deciding, hey, okay, yes, clearly this guy is low risk, or this patient's intermediate risk, and then trying to decide in that risk category, what are the treatment options. So let's go through this a little bit, these different risk categories of localized disease, and think about the treatment options and how technology can impact them. So actually, Daryl, I'm going to take one step backwards though. We talked about the MRI, and we talked about the MRI in the setting of a man not knowing he has prostate cancer, but helping us to decide to do a biopsy. But where the MRI can actually be useful is in a patient who has had a biopsy before that was negative, and you're still worried about him having a high PSA. Are we missing a prostate cancer? So he had a negative biopsy. He hasn't had an MRI before. And that's really perhaps where the MRI is most useful. So that's a place where the MRI can be useful. And then also it can be useful in following a patient on active surveillance. So if we're going to have a patient who's got a lower risk category prostate cancer, then we might get an MRI to see what their prostate looks like. So we know he has cancer, we're getting an MRI, and then as we follow that patient, because one of the components of surveillance is periodic biopsies over time, and so that MRI can give us a roadmap. So I just wanted to address that, where the MRI really perhaps can be useful. So as we talk about the different treatment choices for the different risk categories of prostate cancer, the other thing to talk about is which patients need additional tests that we would recommend. And so in the patients with low risk category prostate cancer or intermediate risk category prostate cancer, they typically don't need any additional tests. But in patients who have sort of that intermediate unfavorable or higher risk prostate cancers, then we think about getting standard imaging tests. So these would be either, well, it would always include a bone scan, but some sort of what we call axial imaging, a CT scan or an MRI, to look at the soft tissues, especially the lymph nodes and so forth, for any evidence of metastases before we say, hey, yes, let's do a treatment to the prostate, because we want to distinguish, do they have metastatic disease or their disease confined and localized? So those would be the standard kind of tests. And so there are certain even more elaborate tests that can be obtained that we can talk about later at the more advanced disease state, but these would be certain types of PET scans and PSMA scans, but those aren't actually typically very useful in this stage when we've just diagnosed a person with prostate cancer. So we would get the sort of standard imaging. When you look at these guidelines, our professional guidelines, here they talk about, though, also these additional tests, and these would include, in the patient, especially kind of in the intermediate risk category, low risk category, some of those molecular tests we talked about, if that's going to help a patient decide on a treatment choice. And those are sort of optional things. So, oh, excuse me for a second. Sort of optional things. And then if we find that he has high risk cancer or has certain pathologic features, one of these is an cribriform or intraductal component in the biopsy tissue. We'll often say, hey, let's get germline testing, to look for these common genetic factors, especially the BRCA2 gene mutation. So, so when we think about these different risk categories, we may apply certain tests as a routine standard. Okay, now, sorry, to get back to, so we talked about the surveillance patient. We may get an MRI in that patient. We may get some additional molecular test on the tissue, one of those Prolaris or Oncotype DX or Decipher. Now, but really the next category, the intermediate risk category, is really where, we're starting to think about different actual treatment choices. And these are maybe surveillance. If it's an intermediate favorable risk prostate cancer, yes, we'll think about surveillance. Or if it's an elderly patient with other health problems, we'll think about surveillance, or even just watchful waiting or observation. But then in a younger healthy patient, we're starting to think about doing something, either typically surgery or radiation. And so here is where technology has kind of made things confusing, because the two mainstays of treatment are surgery and radiation. And in surgery, the robot really sort of revolutionized things. And for most men in the United States, if they're to undergo a radical prostatectomy operation, it's going to be done with a robot. And interestingly enough, the decision to transform from the old-fashioned open surgery of the prostate to robotic really wasn't based or driven by any research studies, but really by the marketing of the robot. And subsequently, some randomized trials have come out, but that essentially a huge transformation in the surgical treatment really was not driven by research performed before. But there are clear advantages to it, and it's still an operation, and those side effects that we worry about, incontinence and impotence, those are there. The likelihood of curing a person is about the same, but in terms of a recovery and bleeding and likelihood of needing a blood transfusion and some other subtle outcome differences, we could say maybe for those reasons it's actually worth it to have the surgery done by the robot. But the fact of the matter is, it's most urologists who are doing this frequently are now using the robot.
Yeah, and it's I mean, you're right, there are certainly savings in terms of time in hospital,
Right.
some risk, particularly around infection and stuff, I think. There's also different kinds of discomforts for patients after surgery. I mean, you're filled up with gas, to
Right.
a much
Yeah.
higher degree.
Yep.
But I think perhaps something to consider is this sort of developed versus lesser developed country thing, or
Right.
regional
Yeah.
things. I mean, there are still many regional hospitals in the United States that cannot afford the Da Vinci system, and also, even if they could afford it, they don't have the time or the capacity to train, or for their local urologists to train. Even
Right.
urologists who are moving from an urban center to the middle of wherever,
Yeah.
there's still, you have to, it's not something you just pick up in a few hours. I mean, you might have a weekend of training, but really you want to practice on,
Right.
things. So there's the cost, the societal cost, what does it take for patients to get the treatment they need
Right.
versus having access to the latest technology
Right.
if, the benefits are minimal. That said, it's really cool that we have it. By the
Right.
way, I mean, robot, I mean, it just occurred to me. I mean, it didn't just occur to me, but this might be a good moment I mean, it's not a robot where you just, it's not some, thing with a
Right.
humanoid face that's doing the
Right.
surgery. It's
Right.
really like a bunch of levers distantly controlling very precise tools and with a good 3D view port, inside the body. Well,
Right.
there's really cool and a cool light shining around in
Yeah.
there. Yeah. So, patients should feel comfortable. There's a person, a
Right.
surgeon, actually operating every aspect, every split second of it, to the
Right.
point where it's, and correct me if I'm wrong, but it's so sensitive that you have to, if you're about to cough or something, you could sort of step on a clutch to sort of remove the vibration of the surgeon's body, through that, that might be carried over into the port inside the body. Is that how sensitive it is?
Well, yeah, you can certainly just once you just remove your head from the console, then it sort of disengages the controls. So, yeah, so it's quite responsive, and but in terms of, yes, the vibration, we all have a natural tremor, and in our hands, and that sort of smooths out these kinds of tremors and so forth. It can even, it can scale our movements, our hand motion on outside uh, to downward, so that if you move 2 inches on the outside, it can move only 1 inch on the inside. So you can adjust the settings, so for a scaling effect, so that you can ideally be a little more precise than you would just one-to-one kind of direct human hand to tissue.
So that brings up actually another extraordinary advantage, in that an older, later stage surgeon who might have retired because of hand tremors might have another year or two of opportunity to do good care for patients because of this sort of dampening effect.
Right. Well, I think it's six of one and a half dozen the other, because what often happens is, as we get older, as doctors, our ability to take on new technologies and so forth, or we sort of get set in our ways, and the ability of people to change and adapt isn't 100%. There are plenty of urologists who sort of in the second half of their career have taken it on and become widely respected, high volume experts. With the robot device. But I think in terms of our doctor longevity, I do agree with you, because one thing is actually, it seems funny, but when we're doing the robot surgery, we actually sit at the controller. So we're actually quite comfortable and relaxed. And in some ways it takes some of the stress off, and not only the mental stress, but also the physical stress. And so I think that really does help increase the longevity of the doctor's career, actually. Plenty of the old time urologists who've been doing the old fashioned prostate surgery is a little bit difficult, because you're actually bent over and your neck is often straining because the prostate's way down in the pelvis. So it actually can be a physically challenging operation and take its wear and tear on the doctor, actually.
Yeah, and there's also that burning thing, where you get the smell of the
Oh,
burning
right.
flesh, the cauterization thing as you're over the body, over the abdomen. Or
Yeah. And
maybe
then
you can talk about that just briefly. It's sort of interesting.
Yeah, yeah, there's some carcinogenic risk, presumably from that inhalation of those things. That still happens with the robot surgery, depending on the energy electrical device that's used for cautery. But there's the contained suction and things like that, so that can pull out the smoke and things like that. So and even for the old-fashioned kind of surgery, there's new containment suction devices so that, to prevent that risk. So yeah.
Thank you all surgeons for taking that risk. I mean, there's so many different things. I mean, we'll get back to our test discussion, but in light of COVID and all, I mean, we don't,
Yeah.
we sort of neglect to remind ourselves that doctors, nurses, technicians, radiologists, people doing everything around keeping us alive and healthy and relatively pain-free, et cetera, et cetera. There's risk, there's genuine environmental risk around that impact, that kills doctors and nurses and technicians. And it's not like on a 50% level, perhaps,
Right.
but I mean, well, but it still exists. It's not like a 19th century phenomenon.
Right. Yeah.
So I mean, I think we as patients and we as people should be ever grateful and remind ourselves there's risk in the hospital by those who work in hospitals. Yeah.
Sure. But I think most doctors have, have altruistic motivations for their work and so forth.
Yeah.
But
Let's return to testing.
oh yeah, okay. Actually, Daryl, can I do one other
Sure.
or not topic, but now the other, like we started to talk about when we have that intermediate risk prostate cancer and certainly the higher risk prostate cancer. So we talked about surgery as one treatment option and the robot and that kind of technology. The other treatment option we talk about is radiation therapy. And so radiation therapy is this big broad lump of treatment choice, but there's subtlety in that as well. And when we divide radiation therapy, we can divide it up into different sort of aspects of radiation, and those are a form of radiation that's an internal implant. We talk about brachytherapy in the seeds. So that's an internal implant of a radioactive containing seed of sorts into the prostate tissue. And so that emits radiation through from the pellet into the surrounding tissue. And it has a relatively short half-life, so that radiation effect decays fairly rapidly. But the idea behind that is that it can keep the radiation treatment localized. And then the duration of treatment is relatively short. You just put in those implants and the person's done. So whereas the other form of radiation, so we talked about there's the implant, you put it into the tissue. The other form of radiation is external beam radiation. So the source of the energy is outside the patient, and then it's being directed down onto the prostate from that external source. And so we typically talk about the radiation now called IMRT. And so the radiation doctor can kind of make a map of the prostate and on their machine program it so that the dose of radiation, the amount of energy being delivered, is sort of focused, a little bit more radiation energy to the main part of the tissue, less on the outer rim, so it doesn't injure the surrounding structures. So so that's the kind of thinking about radiation treatment, and the two can be combined. Even you can kind of shorten the radiation by putting in the seeds and so forth. But the radiation, especially that external radiation, now is becoming even more complex. And we talk about the radiation being delivered in a shorter duration of time. And so that means each treatment is a higher dose. So we call it hypofractionation. So the radiation doctor can try to get all that treatment in a shorter period of time. And so recent data shows that it's certainly not less effective and sort of equivalent to a broader treatment period. Now that brings up sort of this newer kind of radiation machinery. And there's one, it's really sort of known by its brand, but they call the CyberKnife, but the shorthand is the SBRT, stereotactic body radiotherapy. And so for prostate, that treatment can be really delivered in a very, very short period of time, somewhere in about 5 days even. So a person can come in, just get the treatment and be done. And so that's very, very appealing because of convenience. You're avoiding an operation and the problems potentially with that, but getting the benefit of a form of radiation treatment, but packaged in a very short period of time. But the issue with it too is that even though is very, very appealing from that standpoint, but whether it's effective or not compared to our more traditional forms of radiation remains to be seen, especially for the worst cancers. So for perhaps the low and intermediate risk cancers, it may be effective, but we don't know yet for the higher risk prostate cancers. So that's the stereotactic radiation. But the other form of radiation therapy that's also an external radiation that people hear about is proton therapy. And that's simply using a different form of radiation energy, protons. And there are a few centers throughout the country, and the idea is that the proton, the beam, the energy doesn't penetrate the surrounding tissues as deeply, and so the so in that way that the proton therapy may be appealing, but theoretically that advantage exists, that the depth of the penetration is shorter into the surrounding tissue. So you can imagine there's less injury to the surrounding structures from the radiation treatment. But oddly, the research data that's out there that exists that compares proton versus standard radiation hasn't actually shown these critical differences of better cure rates or fewer side effects. So so um, so that remains to be seen. And while we're all improving our treatment choices, that perhaps we'll discover benefits in the future. Now, the other thing I want to talk about was that there are some ways that we know, some technologies we can apply to hopefully reducing some of the side effects of these treatments, especially radiation. And one of them is placement of markers. So the urologist, just the way they perform the biopsy to take a plug of tissue out, they can actually we can implant a little marker in the prostate tissue. It's typically made out of gold because it's an inert metal. And that can help the radiation doctor focus their treatment on the prostate tissue. And so because the prostate is going to move, if the person's bladder is full, or if if they haven't had a bowel movement, then the prostate can move a little bit. So that can give the radiation doctor a more precise target. The other thing that's sort of emerging is a technology where we put a hydrogel spacer, it's called. And so you inject this kind of hydrogel in the space between the prostate and the rectum, so it just kind of separates the two, makes a little margin there, and then and so when the radiation treatment's delivered, there's a little bit more space that between the two structures, so that ideally less injuries as you're irradiating the prostate up top, there's less injury to the rectum below because of that increased space. So this and it's just inserted in the office, this hydrogel spacer. So
There are people who, I mean, so with using our support groups, we get a lot of feedback, and of the multiple dozens, perhaps 100 or two or more, who presented with this idea of hydrogel of spacer or whatever
yeah,
to their doctor.
yeah, yeah,
The radiation oncologist says, I don't need it. I'd rather radiate. I can get right up to the edge. I'm not going to screw you up. So is this an example of a yet to really bear fruit technology, or is it just like some doctors think it's really cool and others are still cynical or skeptical?
yeah. You're right. It does seem like theoretically there's a benefit. There's one randomized trial that does show benefit. Although if you look at that research trial closely, you could maybe say that there's some subtle flaws in it. Wasn't maybe powered well enough to answer their ultimate endpoints. The differences in the patients who got it are the differences determined really clinically meaningful. You know, so yeah. So on the one hand, I guess you could say most patients don't necessarily need it. And certainly some radiation oncology doctors might say, you know what, I prefer for an individual patient not to have it. Let's say if the patient has a worse cancer and they want to get that dose right up to the edge, of the prostate and the rectum, and accept that they're giving a little bit more energy to that spot because they really want to make sure they're getting as much radiation to the prostate tissue, that they may prefer not using it intentionally, even having it available. So You're right. It may be a technology in search of an application, but and so if I have a patient, I would always defer to the radiation oncologist because they're the one treating the patient and wanting it placed. And then ideally, they'd send the patient back to us to place it in the urology. So it's a relatively minor procedure to do, but you need some equipment to be specialized equipment to be able to do it. Yeah.
Yep. All right, what's next?
Daryl, can I go?
Oh, are you exhausted? I mean, gee, I mean, we have like at least 5 or 6 hours of bandwidth to eat up. No, this has been insanely helpful. I don't know why insane is sort of considered a verb for quantity, but it's I guess from Steve Jobs's use of it. But we're very, very, very grateful for this talk. There is, I mean, obviously there's a lot more to talk about, but you also have patients and you also have to you have to not exhaust yourself. Dr. Dash, thank you for being part of our conference. Thank you for taking care of your patients with the care I know you give them. And yeah, and welcome to the conference.
Oh, thanks, Daryl. I'll look forward to hearing the other speakers. It's got an exciting agenda.